greetings, everyone, and welcome to the IPHAM Seminar Series. Today's presentation is held in partnership with the Osher Center for Integrative Health. I'm Dr. Melinda Ring, the director of it. And this is the first of this year's Osher Center Grand Rounds. I'd like to just take a moment to let you know we will not be monitoring the regular chat. If you have questions for Dr. Lio, please use the Q&A function. And before I introduce our speaker, I also want to invite everyone to our upcoming free symposium, you can see that here, on integrative approaches to longevity and healthy aging. It's coming up November 3rd, and talks will be on everything from exercise and nutrition to those trends like cold plunging and hot therapy and wearables. And speakers will come from across the 10 U.S. Osher centers, which include, besides Northwestern, other esteemed institutions like Harvard and UCSF, Vanderbilt, and others. We already have about 800 people registered and cap at 1,000. So you can click on the QR code if you want to register. Again, it's free. And I will also drop the link in the chat for registration. So now on to today's presentation. I have the honor of introducing a colleague that I think so highly of. Dr. Peter Lio is a clinical assistant professor of dermatology and pediatrics at Northwestern's Feinberg School of Medicine. He received his medical degree and dermatology training at Harvard Medical School, during which time he also completed formal training in acupuncture. Dr. Lio is the founding director of the Chicago Integrative Eczema Center. He speaks nationally and internationally about eczema and atopic dermatitis, as well as integrative medicine for all kinds of dermatologic conditions. He's a board member and scientific advisory committee member emeritus for the National Eczema Association and a founding faculty of the Integrative Dermatology Certificate Program. He has hundreds of publications and multiple textbooks and has received a Leader of Distinction Award, a presidential citation from the American Academy of Dermatology, and numerous teaching awards. He is a wonderful teacher, clinician, and just human being. And in sum, he is the perfect person to teach us today about integrative approaches to atopic dermatitis. So I will turn it over to you, Dr. Lio.
Thank you. Thank you so much for the kind introduction. And yes, I'm very excited to talk about these approaches because atopic dermatitis is my main focus in my clinical practice, and it has been a very exciting time. We are seeing all these changes. That being said, there is still a lot of room to bring in integrative approaches. So we're going to jump right in. These are my disclosures. I get to work with a lot of companies developing new products. And the good news is really there's not going to be any products in here. Everything we're going to be talking about are botanicals and natural things. I think we have to start with recognition that atopic dermatitis is really difficult to treat. And when I came back to Chicago after my time in Boston, Dr. Amy Paller, one of my mentors and my chair at that time, said, you know, you can't just be undifferentiated. You have to pick something within dermatology. And I said, well, I like all of medical dermatology. And I said, I don't know what I want to pick. And she said, well, you need to do atopic dermatitis because we need you there and it's really hard. And indeed, this is a quote from 1881. This is L. Duncan Bulkley, who said, eczema has been rightly called the keystone of dermatology, and he who fully masters its management is not only skilled in regard to treating one of the most common and distressing of all cutaneous diseases, but has acquired a knowledge of the principles of dermatologic practice, which will assist in the treatment of many, if not all, other maladies of the skin. I absolutely love this because I think it's true. Being good at treating atopic dermatitis means you kind of can treat anything because you have to pull so many things out of your hat for these patients who are really suffering. And it makes me think back to Paracelsus, a very interesting figure, kind of an iconoclast in his time, definitely rejected by his peers, going against the grain. He is often called the father of toxicology, but he's also relevant to dermatology, the father of balneology, of spa and bath therapy. Amazing figure. And he said, quote, if disease put us to the test, all our splendor, title, ring, and name will be as much help as a horse's tail, unquote. And I totally agree. I am humbled every single day of my life by atopic dermatitis and tough patients. And sometimes people shadowing me are like, boy, we thought you were going to have magic or special secrets. And I'm like, this is really hard. A lot of what we do is we try to connect with our patients. We try to help them. We try to use all the tools in our toolbox. And that's really what I want to kind of convey today. This is what brings us here. This is one of my patients who really was suffering. The patients with atopic dermatitis are miserable. They're itchy, they have pain, they don't sleep. And of course, when kids don't sleep, the whole family doesn't sleep. So everyone is really, really in a bad state. I often feel that I get to meet these wonderful patients and families at some of their worst times. They're kind of the worst they've ever been. They're crabby, they're exhausted, and they're really oftentimes very, very distrusting of the medical system. And that makes our job really, really tough. At its fundamental core, this is my favorite figure for atopic dermatitis. This to me explains everything so beautifully. And this is the one that I really want to get tattooed somewhere on my body. I think it's the most incredibly just concise and really brilliant sort of conception of this condition, because it puts all of the pathogenic factors in a loop, which is so important because we know you can start at any point on this loop and then bring all the others in. So starting at the top, we have the skin barrier. We know that in patients with atopic dermatitis, they have leaky skin barrier, water gets out, allergens, irritants, and pathogens can get in an abnormal way. Going counterclockwise, we know that results in dysbiosis. The microbiome starts to fall apart. Particularly, we see a lot of Staph aureus overgrowth in these patients. It becomes dominant. And we know it's releasing a number of different factors, toxins and PAMPs that actually drive inflammation. That inflammation, immune system may be trying to help. It's like, wait, what is going on here? We have all this abnormal bacteria here releasing all these toxins. Then the immune system is trying to do its part, releasing a bunch of inflammatory mediators, things like IL-4, IL-13, which of course not only continue the cycle of driving itch. We can see that sensory nerve at the 3 o'clock position, but also go directly back up to the 12 o'clock position. They damage the barrier directly. So now we have cycles within cycles. And then of course, that last little piece is the little hand scratching, right? So that scratch behavior stimulated by the itch further damages the barrier. And voila, you have this terrible vicious cycle that can start from any of these. And this is how I meet patients. And they say, well, what's the root cause? And the truth is, at this point, we don't know, and it almost doesn't matter because now everybody's involved. You know, at this point in the game, it's kind of like a giant wildfire. It'd be nice to find the person. Maybe somebody was, you know, committed arson. Somebody threw a match on the ground. But at this point, it doesn't matter. The whole forest is ablaze. And even if we found that little kid who was playing with matches, wouldn't do us a lot of good now. We have a real serious situation here. Our goals with atopic dermatitis are threefold. And I talk about the 3 great hurdles. We first have to get people clear. Then we have to keep them clear safely, and then they have to be able to keep it up. So sometimes I do these very elaborate plans with all sorts of stuff, and the patient's like, yeah, no, this is not going to happen. So that's stupid. That's not going to help them. If my plan is too ridiculous and they can't actually stick to it, that's not a good plan. It might seem good to me, but it really has to be something they could do. So these are the 3 hurdles that I face every day. Usually I can get people clear. The big problem happens keeping people clear safely, because you can give somebody a 1-pound jar of triamcinolone. You could almost everybody a heck of a lot better in a short term, but you're not supposed to keep doing that, right? We know we will damage the skin if we keep using steroids without a break. You're going to thin the skin. You're going to cause stretch marks. You may even have systemic absorption, particularly in kids. They're using so much. We can get really, really into deep trouble. But my patients come back over and over and say, boy, the last dermatologist just gave me 11 refills and said, keep using it. I guess you need more steroid. And they're really frustrated. So part of the exciting thing for me is to use integrative approaches, particularly at that second hurdle, for people that say, boy, I'm using the steroids or using the conventional medicine, but I'm not staying clear. So we can bring some of these other things in, and many times we can make a difference between somebody who might need a systemic agent and maybe not. We can actually potentially hold that off, which is important. These are from the Asia Pacific guidelines now about a decade ago, but they're still extremely relevant, because the concept here is that I wish we could just turn it off. I wish we could just cure it. We can't yet. Hopefully one day it's in the sites, but maybe not yet. But our goal really is to get that unstable disease, which again waxes and wanes, right? People have a bad flare-up, then they're better for a while, and they have a bad flare-up. We want to get it down to the point where we have them under good control. And when I talk to my patients, I show them this and I say there might be some little flare-ups. It's not uncommon in the first few months that we will have little flares, and it's a setback, but it's not the end of the world. And it doesn't mean it didn't work. On the other hand, because it's waxing and waning, there is a gigantic opportunity for placebo effect or for misattribution errors. People say, oh, I'm so miserable. I'm so miserable. I'm going to try magical treatment X that I bought on the internet for $99.95 and I got better. Or I'm going to try a major dietary change and I got better, right? So this is difficult then. We say, well, was it the treatment, the intervention, or was it the disease? Because a lot of those patients then come to see me and say, well, I was better for a little while and now I'm bad again. And I'm saying, I'm not sure if you just didn't start it at your absolute worst point. If you started at your worst point, there's kind of only one way to go, get better. And this is a real troublesome piece for us and any disease that waxes and wanes, of course, but it's particularly difficult when we're looking at evidence because a lot of our evidence is very small in this domain. Of course, we know that. It's integrative practitioners, we don't get the luxury of gigantic thousands of patient studies over multiple institutions. We often have little case series and case reports, and that makes this even harder. This is an important slide. This is actually from the 2018 European guidelines. And I like this a lot because the new update is more complex. And I think this is even cleaner because it talks about this therapeutic ladder, kind of a stair-step function, the way we treat this disease conventionally. Now, it's out of date because there's been so many new things, but I've added them in. You can see my little text on top. But the baseline therapy for everybody, get good education about the condition, good moisturization, gentle cleansing, and avoiding things that they're allergic to or that are irritating, that can trigger a flare-up. For the lucky patient, and there probably are millions of people that really have such mild disease, if they just do this, kind of take good care of their skin, avoid triggers, they're great. And that would be awesome. That's what I want for everybody. I am not interested in pushing medicines. And I always tell my patients, I want to be rendered obsolete. I want you not to need me. I have a long waiting list. I'm trying to help people. I really want to help people that need me. I don't advertise. I don't want any extra business, right? I'm really here for the patients who are miserable. So my dream is that you won't need medicine. And my dream is if you do need medicine, you need it for a short period of time. And I think my patients appreciate that philosophy. That's not everybody's philosophy. That's mine. So if that's not enough, though, everyone should do that. Even the most severe patient in the universe has to be doing that at baseline. If that's not enough, we can be reactive. We can say, okay, you're having a flare-up. Let's just see if we can cool this down. And usually we will use our topical steroids. Are they a bad word? I mean, a little bit. They have a lot of potential issues, but they're incredibly accessible. Almost every patient can get them. They're incredibly reliable. This is something we don't talk about in drug studies particularly, but this is a concept I want to really think about more. Reliability. When I give somebody a topical steroid, I would say 99% of them will respond. They'll have some improvement to it. As opposed to, for example, one of the newer agents, let's say crisaborole, which is a phosphodiesterase 4 inhibitor, topical. Not a bad drug. I still use it. I like it. This is not to impugn it or throw it under the bus in any way, but only a fraction of my patients actually do well with it. A big group says it didn't work or stings and burns. So that's important, that reliability, that I can count on something is part of why steroids are at the top. Number two, because they're really, really cheap. We can get them for like $5 to $10 for a lot of them, but that's be reactive. Oftentimes we'll pick that first. When you flare, you use it. When you're better, you stop. For a huge swath of patients, that is enough. It's fantastic. Those patients never make it to me, but that's wonderful. They use a little steroid from time to time and they're fine. Great. Go out and do great things. Don't worry. That's where that hurdle number two comes in. Are you able to stay clear? What about the patients I put it on, I get better? As soon as I stop, it flares up. So I find myself using steroid nonstop. That's where we get into that moderate zone, the next level up. Here, we start talking about proactive therapy. Usually, I like to use a non-steroidal agent. This is very similar to how people have treated asthma. Asthma people are way ahead of us. You can treat an exacerbation, but when they're better, if they're having a lot of flare-ups, give them something more chronically to help maintain. And that's really where our non-steroidals, and frankly, this is where a lot of my integrative approaches come in too. So things like tacrolimus, pimecrolimus, we have topical ruxolitinib, a JAK inhibitor, we have crisaborole, we have a couple of new agents coming, tapinarof and roflumilast, we have a lot. And then what if that's still not enough? Then we go to that final level and we really have our big guns there. We have our conventional immunosuppressants, we have hospitalization, we have phototherapy, which I do use a lot as well. And then we have our biologics, which are really exciting. Currently in the US, we have dupilumab and we have tralokinumab. We were supposed to have lebrikizumab. It's coming. It got delayed. It was supposed to be approved this month, but it looks like it's going to be a few more months before we get it. And then we have two oral agents, the JAK inhibitors. In the US, upadacitinib and abrocitinib. In Europe and Japan, we have baricitinib, but in the US, that's not approved for atopic derm. So we have a lot of potential things we can use, but with each one of these things comes some caveats and lots of issues. So I use all of these kinds of tools for my patients, but many of my patients want something different or want something more. And the way I conceptualize atopic dermatitis, as we saw with that loop, we can break those into 5 pathogenic pillars, 5 things that are broken in this disease, and we can break them apart and see that each one we can address: the barrier, the psyche, that mind, body, or behavioral connection, inflammation, the microbiome, and itch. And I use this rubric to help me sort different treatments that I learn about. So when I learn about a new botanical, I'll say, now many things do multiple things, but I'll say, I think this might go really well here. This one might go really well here. This technique goes into psyche, so we'll talk about how I use this with the idea that we can really put this together for every disease, not just atopic derm, but for any and every disease. And then we can have these integrative choices on our menu. Now, we have to filter it out, because one way of defining alternative or complementary medicine is everything that's not evidence-based, right? Well, that's a universe that's infinite. The 3 most important words in science are I don't know. And I say that a lot. Patients tell me crazy stuff. I heard about this special oil from a special supplier somewhere. What do you think of it? I don't know. I've never heard of it. I don't know anything about it. What about this crazy technique I learned about from my cousin? I don't know. So a lot of times I don't know. So I'm trying to look for things that have some evidence, that we have general reassurance of safety, and they have to be practical. So for example, I'm a big fan of traditional Chinese herbal medicine, right? I think it's fantastic and it's helped a lot of my patients. I can't do it because it's not practical for me. You have to really study for at least several years of intense study. You need to have a supply chain. You need to make sure your herbs are good. So when I need someone to do this or someone wants to try it, I refer them to a colleague who specializes in it and knows what they're doing. I don't think it's right to dabble in that. Just like I wouldn't dabble in plastic surgery or liposuction. These are not things you dabble in. If you're going to be good at it, you really want to do it all the time, with the goal of creating, for regular clinicians who are not going to specialize in one of those zones, in a multidisciplinary integrative toolbox of techniques and treatments that we can call upon. So that's what I've been trying to build and continue to build. It's a work in progress. And really today, I just want to update you on some of the things that I've added, and maybe you can add them to yours too. You can kind of experiment and see what you think and read about them. But I think it's kind of neat. So again, we take the words of Paracelsus, who he admonishes us to seek, knock, and find. And that's really what we want to do. I'm always looking for new things, and I'm always seeking. So let's start with the barrier, a very important area. We know the skin barrier is super complex. It's not just brick wall, right? It's not bricks and mortar. It's a very functional living barrier. And it has a lot of aspects, from the microbiome to the chemical aspects, which include things like cathelicidins and beta defensins, and even the lipids like ceramides. It includes the pH. We know Marchianini's acid mantle is really important. Our skin has to remain acidic. If it becomes alkalinized, we can have all sorts of dysbiosis and problems. The enzymes start to function differently. It makes a mess. And of course, the immune system. So all of these are part of this barrier story, making it a microcosm of the whole. We often see that as above, so below. We see this echoed over and over in medicine and the universe. One of the most exciting concepts, though, about the barrier makes it even bigger than just thinking about dermatology. And this is from the work of Jesme Actis, a wonderful allergist who's written a lot about this concept of the epithelial barrier hypothesis. And in sum, it's that there are environmental agents that damage our skin barrier. This results in that leaky skin and basically puts us into that loop we saw before: inflammation, colonization of opportunistic pathogens, and then it continues to propagate this cycle throughout the body. Why does it matter for us? Well, it matters for us because this is not just about stopping atopic dermatitis or cooling it down. This has bigger ramifications when we think about the allergic march moving forward. And the most important one, at least in my opinion, is food allergy, which affects an awful lot of people and is really debilitating for a lot of patients. It turns out that one important route of developing food allergy is through the skin. So this concept of epicutaneous sensitization is really, really important. And when I have families who are treatment hesitant, they're saying, well, we don't really want to do anything. Just let the baby be. Won't it get better in time? I say, first of all, it might not. A lot of patients with eczema get better, but it is definitely a myth that needs to be busted, that everybody grows out of it. And I have legions of teenagers and adults who will scream at you if you try to argue with me there. I have a whole bunch of people who say, that's a bunch of baloney. Everybody told me I grow out of it. And here I am. I'm 20, I'm 30, I'm 40, I'm 60, I'm 80, and I still have atopic derm. So it's not fair. We really want to bust that myth. We don't want to tell people, just wait, you'll get better in time. You might not. Some do, yes, but maybe not. So that's important. Number two, we really think there is a time course on this. So the longer this rages, the more likely we think people are to become sensitized to foods in their environment. And some of those food allergies you never grow out of, right? Some you might, maybe milk, but maybe not peanut, maybe not shellfish. So what if we could prevent even a portion of this? And the answer is, we don't know, but there is some evidence to suggest that yes, this actually is at least one of the key mechanisms. And so that's why I really try to push for treating. But what is the root cause? How did we get here in the first place? Why is the barrier disrupted, right? A lot of times people say, well, it all begins in the gut. Maybe, but let me ask you something about the gut, right? What is the gut? The gut is another epithelial surface, right? Skin, 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 gut. Okay, so just to say it begins in the gut, that doesn't answer my question. It's like answering a question with a question. Why is my gut barrier screwed up? Well, here's why. Here's what we're looking at, and this is Actis's work, that there are many barrier disruptors in the modern environment. And this also helps us understand why we've seen such an increase in all of this atopic dermatitis. So things like microplastics, things like cigarette smoke and particulate matter, particularly diisocyanates that are present in like the California wildfires and the Canadian wildfires. This damages our barriers. We know that surfactants and detergents, right? We have detergent residue in our clothing. We also eat emulsifiers. What is an emulsifier? It's a detergent. That's really what it is. It destroys our barrier. We're eating these processed foods that have this. So gut, skin, and if I do the same trick, skin, 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 respiratory, not to pick my nose in front of all of y'all, but that's a respiratory epithelium. All of these are being exposed to the same thing. So it's weird when people just say, oh, it's just the gut. It's not just the gut, it's epithelium. Our barriers are disrupted. We have to think holistically here. The gut is important, yes, but that doesn't answer the question for me. That just seems like a cop-out. We have to go deeper than that. But this is suddenly, to me at least, deep enough. It's like, okay, modern environment. And it turns out that if we support our barrier, including just the skin barrier with moisturizer, it really helps, like legitimately helps. We can get people better. You can't get a better graph than this, showing more moisturizer use equals less eczema. It's remarkable. And we could go down a very deep rabbit hole about which is the best moisturizer. It's one of my areas of focus. I work with a lot of industry trying to develop new moisturizers. And I will answer it quickly by saying, we don't know. We just don't know. Anybody who's very confident that they have the best moisturizer, look at them with the side eye, because there is not great comparative evidence. And I've written a bunch in this space, but it remains to be seen. However, that being said, getting a good moisturizer, one that is simple, ideally that maybe has a seal, like for the National Eczema Association, something like that, that's been vetted and tested in patients with sensitive skin and atopic dermatitis, you are going to do a great service to your patients. That's awesome. What about some natural things that can help the barrier? Well, sunflower oil actually seems to be pretty neat. Not only does it induce our own endogenous ceramide production, which is great, but it also has an anti-inflammatory effect. And as we said, we want some clinical data. Here was a clinical trial where they actually showed patients who used a preparation with this sunflower oleo distillate, this kind of sunflower oil distillate, did much better than the control group using a more conventional moisturizer and a steroid. And they were able to show that the lichenification, that leathery thickening of the skin, was better at day 7 and day 21. Really neat. So you'll see a lot of commercial preparations have some sunflower oil built in now. It's one of the common things. But this is another piece of data that I love. This is sunflower oil by itself, 19 adults with atopic derm. They had them put sunflower oil on one arm, olive oil as a control on the other, and they actually showed the sunflower oil helped. The olive oil actually seemed to make things a little worse. It increased their transepidermal water loss, that leakiness of the skin. So this is a neat study, very small, admittedly. But I like to say to patients who are using olive oil on the skin, I'll say, maybe that one's not the best. It's not clear, but maybe we could try sunflower. And I think that's a better choice. Coconut oil, we're going to talk about again in a couple of moments, but it also has a barrier effect. This was a beautiful study just from a couple of years ago where they looked at patients using a lot of alcohol-based hand sanitizer, which is all of us, anybody in healthcare. I do it about 40 times a day, and it beats up our skin. They had patients just put some virgin coconut oil on their hands at night, and they were able to show they did significantly better than the control group, especially for those patients who were using a lot of times, more than 6 times per day. So really neat. Coconut oil helps with our skin barrier. And it's fascinating. They concluded that based on the findings, a regimen of overnight virgin coconut oil application on the hands is a natural prophylactic against the increased frequency of alcohol-based hand sanitizer usage is recommended. Kind of neat. Another way we can boost up our barrier is from the inside. And this was a fascinating study that looked at giving people extra L-histidine amino acid. It turns out that the precursor to filaggrin, called profilaggrin, used to be called histidine-rich protein. Now, mind you, this is not histamine, right? This is histidine, the amino acid. And what they found was that both in vitro and in a clinical trial, they were able to show that when you add L-histidine amino acid, you boost the natural production of filaggrin, which is a key component, the key component of natural moisturizing factor. And what's remarkable is they were able to actually show on the trial that it decreased atopic dermatitis disease severity by 34%. The p-value was less than 0.003 after 4 weeks. So I think this is fantastic. And I have my patients do this. Sometimes like you can get it very inexpensively. You can get it online, histidine powder. And I have them take about 4 grams per day, and they can mix it into a smoothie. It tastes kind of bitter by itself. I wouldn't just put it in water, but in juice or a smoothie. And this actually may help us. Now, do we need more data? Absolutely. Should we be a little skeptical? Absolutely. But pretty remarkable scientific underpinning and a clinical trial that shows that it did help, at least as a pilot. Another oral thing we can do to support our barrier is hemp seed oil. And this was a randomized crossover study of 20 adults with AD. And again, they used olive oil control. And again, this is by mouth. So these are internal treatments. And they actually found a significant improvement in the hemp seed group and not much of an improvement in the olive oil group. And this is what it looked like. It helped with dryness, itchiness, and medication use. Look at those p-values, all less than 0.05. Really neat. And this is another thing that I help my patients do. I'll have them take some hemp seed oil and mix it into their smoothie. And here it's about 2 tablespoons per day, which is a bit. It's quite a bit, but you can get it. It's food grade. You can go to the grocery store. This is not cannabinoids. It's certainly not marijuana. This is just the cooking grade, food grade hemp seed oil. Pretty neat. Let's move into the psyche, this mind body. And again, we could spend a long time in each of these areas. So I just want to kind of highlight some of my favorite things. But the psyche is fascinating because we understand that itch scratch cycle is really, really important. And I know, especially in a lot of my teenagers, they'll start scratching when they get anxious. And I'll say, are you really itchy right now? And they'll say, no, sorry, I just do that when I feel anxious. And it's a self-soothing behavior, but it actually has a real effect. You're damaging that skin barrier and driving inflammation. So we don't want people to do that. So there are a few things that can maybe help with the itch and help from this mind-body perspective. So one of them is massage. This is Larry Schachner's study from quite some time ago, 1998, more than 20 years ago, where they showed to 20 kids with atopic dermatitis who got just a 20-minute daily massage from their parents. They did much better than the control group. Decreased disease severity, decreased anxiety. They were better overall. And this actually persisted for months after the study. So what a neat little intervention. I'll have patients, I'll say, listen, can we do like a little nightly massage, maybe with coconut oil or maybe with sunflower seed oil, or even at our office, we make a little combo version. It has coconut and sunflower together with a carrier oil of jojoba. And I say, why don't you do this at night, just 15 or 20 minutes, and then you can put your medicine on, formal moisturizer over that and go to sleep. And when I do this, holy guacamole, does it make a big difference. Now, is there a placebo effect to all of this? Of course there is. I mean, there definitely is. It's, you're touching the patient, you're making them happier. It's also reinforcing the routine at night, which is really huge because we know adherence might not be that great. So there are probably many good things that are coming out of this, but it costs nothing. It's super safe. We're just gently massaging somebody. It's like a lovely thing. So this is why that risk benefit thing, if you want me to prescribe somebody methotrexate, well, there's a lot of risks. We have to talk about that. Is that, is this really going to help? We got to be sure. But when you're talking about massage, it's a heck of a lot easier to spread that message. Now, there's been a whole literature of mindfulness, and I'm just going to kind of summarize it here. But actually, in the past year, we had this study, 107 adults with atopic dermatitis. They got 8 90-minute weekly group sessions of online mindfulness and self-compassion. They compared this to the group on the waiting list, and they actually found, and they could get any treatment for their atopic dermatitis except for dupilumab, except for the biologic. And they actually concluded that, quote, integrated online mindfulness and self-compassion training, in addition to usual care, resulted in greater improvement in skin disease-specific quality of life and other patient-reported outcomes, including eczema severity. These findings suggest that mindfulness and self-compassion training is an effective treatment option for adults with atopic dermatitis. It was published in a fringy journal you've probably never heard of. Oh, wait, never mind. It's JAMA Dermatology, mainstream journal, the #2 journal in our field. Amazing, right? So this is what every dermatologist got to see. How exciting is that? And they did, I love it because it's really an integrative study. They're using conventional treatments, they're adding this on, and they're still showing that it helped. I love this. Now, this is a slightly older paper, a couple of years ago, hypnotherapy. In 27 adults with atopic dermatitis, they got a mean of 6 hypnotherapy sessions. And again, they found that it was significantly improved over time. And I do work with a local hypnotherapist in the suburbs of Chicago, and I have had very, very good luck. Again, it's not going to replace cyclosporin, but it can be a wonderful adjunctive therapy for a lot of people. And recently we wrote a review of psychological therapies and mind-body techniques in the management of all dermatologic diseases. It was a little more inclusive. If you're bored at night and you want to help something to help you fall asleep, you can read through it, but it is pretty neat. There's a lot of good stuff in there that talks about some of the different places in dermatology these have been used very successfully. One of the ones that I'll point out is one of my favorites is habit reversal therapy. And this is really interesting. There are 3 current studies that show that the use of habit reversal therapy can be a good adjunct in atopic derm. And I think there's something to this. Here are those studies. They're quite old, 1986, 89, and then one from 2018. But I think there's something to this. And one of the studies, just to show you what they look like, this is the one from 2018. It was a randomized, single-blind, 2-center study. They had parallel comparing the habit reversal therapy versus mometasone alone. So the steroid plus the habit reversal therapy integrative versus mometasone, the steroid alone. And they did this in kids 5 to 13 years of age. And actually, they found that it made a big improvement. So what is habit reversal therapy? This is the figure from the paper, which is really neat. And literally, it's just a replacement behavior. So instead of scratching, and instead of the families telling them stop scratching, which we know doesn't help, giving them something else to do. So they can squeeze their fists together. They can gently pinch the area as opposed to scratching or rubbing, or some patients even, I had a little girl yesterday scratching it against the sharp edge of the wooden table. I'm like, oh golly, this is bad. So if we can do something like this, it really works. It sounds dumb, it sounds obvious, but it doesn't happen unless you do it. Look at the p-value, less than 0.05. So this really helped with the objective disease scores. Now, another study that just came out in 2023 was looking at patients who have body-focused repetitive behaviors like skin picking, another important problem, and very close to these scratch behaviors that we see. And again, they found a significant improvement in the habit replacement group compared to the control, and the user satisfaction was really high. And we can see those p-values less than 0.001. What I love about this is the intervention is so dead simple. So, quote, in brief, participants in the habit replacement condition were encouraged to perform simple, gentle, circling movements. This was explained in a manual and a video demonstration. And here's the crazy thing. The video is freely available. Like, it's just online. So I actually just give a little card to my patients, say, punch this in, and you can actually see what they did in the study. I give them essentially a handout that looks like this slide. And these are the highlights from the video. It's under 2 minutes long. And there's no spoken word because this study was in Germany, so it's in multiple languages. So they just have the captions in different languages. And literally they're like, instead of doing this, do these gentle stroking movements or do these little tapping. It's brilliant. And it really worked. You have true evidence. And then we put together a little handout if your patients are interested on our website where they can read about it. And again, this is just a neutral thing, but we actually worked with a psychologist at Mass General Hospital in Boston to just approve it and make sure everything seems in line. And she does a lot of habit reversal in her practice, which I think is really neat. Okay, let's move to our next pillar, which is inflammation. And this is a big one because we know inflammation is a huge part of atopic dermatitis. And of course, this is against a backdrop of steroid phobia. Corticophobia is a huge problem. It's a global problem, and it's not necessarily unfounded. I would say this is not an irrational fear. It is a rational fear. Sometimes it's a little bit too much. And some patients, I think, are so afraid of it that it can be actually damaging to them. But I think that it is reasonable to some degree. Of course, that's not the only phobia we face. People are worried about topical calcineurin inhibitors. They have a black box warning, the highest level warning that the FDA can put on something. And right next to that would be the JAK inhibitors, black box warning. They say things like mortality, death, major adverse cardiovascular events. They say blood clots. It's intense, right? It's a big deal. Antibiotics, we keep telling everybody to be better stewards, and then we're giving them to patients all the time. Preservatives, people are worried about preservatives and parabens, chemicals in general. The list goes on and on, of course. So a few things that I found for inflammation that are really helpful. One of them is topical vitamin B12, and it turns out that vitamin B12 topically seems to have an effect on nitric oxide synthase and may help prevent flare-ups. So I really like it in that context. You can use your steroid or whatever prescription medicine for a bit when you're better, and then use your topical B12 to help prevent a flare-up, that maintenance or proactive therapy. And there were 2 wonderful studies. One of them was a phase 3 randomized controlled trial. They had to apply this preparation twice daily for 8 weeks. And they saw a significant improvement compared to the vehicle. Another study validated this. And you can see the first one was in the British Journal of Dermatology. Again, a top tier journal, one of the top 5 for sure in dermatology. So we couldn't get it, and I decided that I want to make it. So I have it made for my patients. This is what ours looks like. And the first patient I gave it to, she came back and I said, "How did you like the B12?" And she said, "I really like it. It feels really good." She goes, "I call it pink magic." I said, "Oh, that's a great name for it." So she calls it Pink Magic. I do not commercialize this product. It's just made for my patients. But I also, on our website, have the recipe if a patient wants to make it themselves. So you can call it into a compounding pharmacy. You could make it for your patients, or you can actually give them this and they can actually make it themselves. I mean, literally, it's just B12 powder, which is not a controlled substance in any way. It's not a prescription. It's just vitamin B12 powder. You can get it online, and a moisturizer base. So these are the instructions. You can try it out and see what you think. It is very safe. It's probably impossible to overdose on it from your skin and so on and so forth, but interesting. But we have it made for our patients for a pretty cheap price, and they like it. Now, another study that came out of Germany just in the past couple of years is this one. This is looking at a topical black tea preparation, a compress. And this blew me away when I saw this. I said, "This is incredible. Look at this. We're looking at patients with severe facial eczema on day 0. The middle is day 3, and the right side is day 6. They had a rapid and dramatic improvement. They did this like a drug study. They have a facial EASY score, the Eczema Area and Severity Index. They have itch scores. They have the investigator global assessment. They have the patient assessment. This is incredible. And if you didn't know, if I started with this slide, you'd be thinking, boy, what new exciting drug is he talking about today? This looks like a fantastic new addition to our canon in dermatology, but it's something you have in your kitchen already. It's black tea. And this has been a practice-changing thing for me. I use this now. It's replaced all other kinds of compresses and things because I think it's wonderful. These are the instructions I give to my patients. Get some unflavored black tea. We don't want anything with bergamot. We don't want anything with flavoring or anything like that. So just a simple black tea. Brew up your first cup. About 10 minutes, you can either drink that tea or pitch it. We want the same tea bag in a second cup, the weaker second steeping, right? That's what we really want. Then we want that to cool down. I tell them to put it in the refrigerator because I do not want someone putting scalding hot tea on themselves. And then throughout the day, they can just dunk a little washcloth in or a gentle soft cloth and do a compress to the areas, safe for the face. That's where it was studied, but I have people do it for any problem areas on the body, and ideally moisturize right after. Why does it work? We don't know. It could be the acidity of the tannins. It could be caffeine. It could be some other aspect of Camilla. I mean, it's a powerful botanical. It does a lot of things, but it does seem to help. What about drinking tea? Well, there is a study that's really neat back from 2001 where they had 121 patients with recalcitrant atopic dermatitis. They were enrolled in this study, and they had them just drink some oolong tea after meals, right? 3 times a day after meals. After 1 month, 63% showed marked to moderate improvement. And people were even noticing an effect in just the first few weeks. At 6 months, more than half the patients still had a good response to treatment. This is what their data looked like. It's remarkable. So marked or moderate improvement in many of these patients drinking some oolong tea. How cool is that? Let us move into the microbiome. And this is a really complex area. This is the area that I'm focusing on right now a lot in my practice. And I'm working with a number of interesting startup companies that are helping me question the whole nature of our understanding. One of the wildest things when I'm in the room with the company as an advisor, they'll show me something and say, well, what do you think about this? Does this make sense? And I say, no, because you don't understand. No one knows any of this. Like, you're actually breaking into completely new territory. Like, nobody thinks about it this way. This is groundbreaking stuff. And it just keeps reminding me how little we know about the microbiome. I mean, when I went to medical school 20 years ago, we didn't really talk about it. There was nothing about it. And now we're realizing this is really another organ system. We need to have an entire unit on the microbiome. And we're going to keep learning. I think for the next 20 years, we are going to get educated on this. I will give credit, I think, to Heidi Kong, who's an incredible dermatologist, incredible researcher at the National Institutes of Health. She really, I think, got this whole party started. She put the horse back in front of the cart, because when I learned about atopic dermatitis, the original conceptions, admittedly, other people have talked about this as being a driver, but not quite in this way. The way I was taught was that it is more of an opportunist, that you have broken skin barrier and staph is out there and it just takes advantage. And I think that is still true to some degree, but it's not quite fully true. It's not completely true. And what she was able to show was that actually staph is a driver of the disease, that before you get a flare, staph actually goes up. And before you get better, staph goes down. So this really changed the way we think about it, that one of the causative factors of atopic dermatitis is Staphylococcus aureus. And now we know why. it makes a whole bunch of nasty toxins. So delta toxin causes mast cell degranulation. It drives allergic skin inflammation. Alpha toxin damages our membranes of our keratinocytes. I mean, this is really poisonous, right? This is really hurting people. And we understand now that if we can get rid of staph or at least keep the balance, we can help people a lot. So this is complex. So how do we manipulate the microbiome? Again, very complex question, right? With a very, very nuanced answer. There are many things we can do because lots of things affect our microbiome, everything from how we eat to our stress levels to the temperature to the kinds of products we're using. Personal care products affect it. And then we have more direct ways to try to manipulate it. Probiotics, viable bacteria. Prebiotics, the food, usually little oligosaccharides that bacteria eat. Postbiotics, dead bacteria that still have some interesting properties. Sometimes metabolomics are separated, the things that the bacteria are making that are doing the good things we want, right? And then, of course, we have our antibiotics, which kill bacteria, but they're kind of broad. They're not quite as broad as an antiseptic, which kills everything, right? Like if you put bleach on something or chlorhexidine wash, right? So holy cow, is this complex, right? All of these things are nuanced. And if we look at probiotics plus prebiotics, you'll hear people use the term synbiotics. Then don't even start when you start saying, well, which strain, dosage, strains? How about if we put a few together? Do we get synergies? Maybe. So that anybody who's confident on the microbiome, oh, I got this all figured out. I could tell you, just let me look at your test. They're full of baloney. I'm sorry, but they're kind of full of baloney because there's so many more variables here. You know, it's very Newtonian. It's sort of like, trust me, we can explain everything. We got force equals mass times acceleration. This will work. And Einstein came along and said, yeah, it works in a small set, but yeah, I don't think you got the whole story. So I think that's the same thing with microbiome. Are there certain things that we can leverage and utilize? Absolutely. But are there, do we got this all figured out? Not even close. One thing I'll dispel right here, will bust a myth, is the bleach baths, right? Bleach baths, when they originally came out, Amy Paller, Jen Huang, they put this study out originally in 2009. It was pretty exciting. And they hypothesized that bleach actually helped the microbiome. We thought, oh, it kills some staph on the skin. But I will bust that myth now. It doesn't. So this was a study from Han et al. This is 2016. And the conclusion was that a 4-week, twice-weekly regimen of diluted bleach baths may not be useful in reducing Staph aureus colonization or infection and improving AD. Instead, regular water baths would be a more efficacious alternative. That was a little low blow. I don't think they had to say that. And I don't actually agree with their full conclusion. But it turns out they were right on in that. We now know we are about an order of magnitude too dilute for bleach to kill staph on the skin. So this is the work out of Rich Gallo's lab. This has been replicated many times now. It's so funny. I do a lot of post hoc reviewing for papers, and inevitably someone will have an antibacterial thing and they'll put bleach. And I'm like, guys, for the past, like now we're probably on the order of like 6 or 7 years we've known it doesn't belong here. We have to move this out. It really isn't. We have tons and tons of great evidence that it's not. To kill staph on the skin, we need to be about 10 times stronger, and that would be terrible, be way, way too damaging to your skin. So do bleach baths still help? I still think they do. They still do. Lisa Beck, Mercedes Gonzalez, others have written papers showing that they're probably anti-itch, probably anti-inflammatory, probably support the skin barrier. But the one thing they don't do is the thing we thought they did, which was kill staph. They don't directly kill staph. So just put that in your memory banks, because you'll hear people say, oh, you're infected, go to a bleach bath. But I mean, it won't necessarily hurt, but it probably isn't going to help the bacteria. What would? Coconut oil. This is what's crazy. Coconut oil, turns out that it's high in these medium chain fatty acids, and it's high in something that's fascinating called monolaurins, or this lauric acid derivative. And what's remarkable about this is that it really can kill staph in situ on atopic dermatitis patients. This is a wonderful study done in the Philippines back in 2008. They had topically applied coconut oil to patients who were colonized with staph. They found that they could decrease that colonization by 95% with twice daily coconut oil over 4 weeks versus the control group. They just had them put olive oil on their skin. They only had about a 50% decrease. And we really do think there is good antibacterial activity. It seems to be almost impossible to get resistance with the laurins. And they also seem to be friendlier. They're not really an antiseptic. It seems to kill some of the bad guys, but leave most of the microbiome in a better place. It really, Mother Nature, it's just remarkable. It seems to be more nuanced than just poisoning everything. So I use this a lot for my patients. Would I use this for cellulitis or real infection? No, right? This is not a replacement for antibiotic therapy or something like that. But can this be a nice adjunctive therapy for patients that are struggling? Yeah, absolutely. I think so. Now, another study compared virgin coconut oil to mineral oil, and again, found the coconut oil was actually better in all the disease outcomes for AD. Pretty neat. So I think this is helpful. Now, before I move on, I'll say one thing. Sometimes people say, well, didn't you say putting food on the skin? Didn't you say epicutaneous sensitization is bad? That's how we make food allergy. So you're telling me to put sunflower oil and coconut oil on the skin. Aren't we going to make allergy to it? And here's the answer. Theoretically, yes, you're right. It's a good point. Practically speaking, doesn't seem to be a big issue. So people have been doing it. Obviously, some cultures have been doing this for millennia. This is not a new treatment. People have been using coconut-derived products and oils on their skin for a long, long time. So it's a very rare allergen as opposed to peanut, which is a real potent sensitizer. So that's interesting. Number two, if you were serious about that, then you'd have to go through your products with a fine-tooth comb, because go to your shampoo in your shower, if you're home watching this or after this video when you get home, and pretty good chance that you're going to see something like cocamide DEA or cocamidol propylbutane on your shampoo bottle. That's a coconut derivative, and that's what we're testing for with patch testing. So if you really are thinking coconut and coconut-related things can cause trouble, the coconut oil is probably among the least of our worries. We use other things that have coconut-derived molecules that potentially could sensitize you to it. But in practice, the truth is it just doesn't. Same goes for oatmeal. We see that in a lot of products. Is it zero? No, I'm not saying it's zero. Can it happen? Absolutely. Do I have patients who are allergic to coconut and oatmeal? 100%. Yes, I absolutely have some patients. It's just relatively rare. Last piece of the puzzle of the 5 pathogenic pillars, itch. So there's so much to say here. Again, it's its own frontier. There's a whole world. Gil Josipovich is the master of itch. Itch is even in his name. He's down at University of Miami. He runs a center for itch. Brian Kim runs a center for itch up in New York City at Mount Sinai. I mean, these are amazing clinicians and scientists who've dedicated their career. So there's so much going on in the world of itch. It's crazy. So I'm going to give you the highlights. Cannabinoids, fascinating concept. Very, very good potential to help us hear pain and itch, but very little data. It turns out the data is kind of sparse. So why might they work? Because they affect a lot of things. They affect lipid synthesis. They affect the nerves directly. They actually affect the immune system in a number of ways. They're cool, but we just have a lot to learn. And the data so far is kind of spotty. So I don't really lean on cannabinoids yet. I was consulting for a company that was really neat. They had a nice cannabinoid product. I found it best for wound healing, but the company went out of business. It's a tough business in part because of the federal regulation stuff. It's still considered, a Schedule 1 drug. It's really tough to, it's confusing. So the cannabinoids are a complex story, but stay tuned. I think there's something to it. There may be other uses yet. Acupuncture is really, really good at inflammation. I think it's one of the things that it can do, and really good at itch, and itch in particular because that mind-body connection. And this was a wonderful study from a number of years ago that blew my mind. 40 patients with refractory uremic pruritus, so metabolic itch. It's one of the hardest things we get consulted on in the hospital. Patient in chronic renal failure. They're so uncomfortable. They're so itchy. We try throwing everything at them. Nothing worked. But they had these patients get some acupuncture once a week. 3 times a week for 1 month. And they did a sham as a control. So they picked like a pretend point as a control. And they actually found that the acupuncture group, the acupuncture verum that actually got the proper points needled, did significantly better. P was less than 0.001. So I wanted to do the same thing in our atopic dermatitis patients, but our IRB would not let me put needles in because the point that they use is called large intestine 11. It's near the antecubital fossa. And they said, wait, you're going to put needles right next to potentially infected. And as you're telling me, staph colonized atopic derm, that sounds bad. But they said, well, we will let you do acupressure. So we did. We had people use these little teeny titanium acupressure beads, and we had them apply it 3 times a week for 3 minutes for a month. And I will tell you that many of the patients told me they lost the beads and just used their fingertip. So it seems to be either way. And that's the point you can see in the photograph there. And it really worked. The patients doing this did significantly better than the no acupuncture group, or acupressure in this story, acupressure group. And this was really neat. A lot of the patients tell me they still do it to this day. Now, is this sort of a form of habit reversal therapy? Kind of, because I would tell them you can do it whenever you're itchy. So in a way, we kind of married acupressure and habit reversal therapy all in one. But how cool is that? It may help for multiple reasons, and it really made a difference for these patients. So I still teach about this all the time. I say, hey, if you're feeling itchy, instead of scratching, why don't we try doing this? Pressure on that point, gentle pressure, very safe, costs nothing. Generally speaking, the worst it can do is not help them, but at the very least it can do is maybe give them a distraction. So how do we put all of this together? That was a lot of stuff. And of course, that's just the tip of the iceberg on this. The most important thing I think we can do to bring these together for a patient is to make them a written plan, write out a plan. And I can't emphasize this enough. When I do this for patients, I do this for every single patient. I can't even imagine practicing without it. But when I do it, patients often say to me, no one's ever done this before. No one's ever written it down. And I'm like, I can't, how do they even talk about it? How can you even explain to anybody all this stuff? Because you could see there's a lot of steps, a lot of pieces of the puzzle. So my sample here would be, and I always separate it into two pieces. When you're flaring up, we have a rescue concept. So you're going to do something to help you, because I don't want the call. If I just give them something to do for maintenance and they're miserable in 2 days, they call me and say, well, what do I do? I'm really itchy. So when you're flaring up, when you're itchy, red, oozy, you're going to do this. And usually that's where you say, I have mometasone, I have a steroid there. Do that twice a day. Of course, I'm building in gentle cleansing, good moisturization, all those other pieces. When you're better, though, then I like to give them a break. So a conventional better plan might have tacrolimus, non-steroidal. It might have something else. Maybe it would have crisaborole, one of those things. But what if we wanted to build an integrative plan? Well, here's an example of an integrative plan. Maybe we'd use that pink magic, the topical vitamin B12. Maybe as part of my integrative approach, I would have them take vitamin D, which we didn't get to today, or probiotics, which we only touched upon today. But I think there's compelling evidence for both of those, supplementing those in patients with atopic dermatitis. And what if we also had them do something behavioral? And we could bring all these pieces together in a plan, write it out for them, explain to them the why behind everything we're doing. And I really think that if we do this for our patients, we can get them better than ever before. We can make them feel confident and empowered. They don't feel like they have to call us or feel lost. They know the order of operations. And the goal is, again, making ourselves obsolete, right? That I want them better, so that all they say is, that guy was really good. He helped me get better. I don't need him anymore. So in conclusion, modern medicine, we have some amazing treatments, right? Some of the best, but in part is because we're not afraid to keep looking and taking and learning, right? A lot of our best treatments came from botanicals. They came from, Paracelsus himself. I mean, his big thing was all of the academe was making fun of him, saying, you're following around these midwives and local healers. These people have nothing to offer. And he's like, you are wrong. These are clinicians. They are actually in the trenches and they are doing things. Now, maybe some of the stuff they're doing is incorrect, but some of the stuff is really brilliant. And our job is to help and learn and see what is good and help separate the wheat from the chaff. And he did that. And I'm trying to do the same thing in his spirit. And of course, most importantly, I think we have to convince our patients that we're not know-it-alls. We don't have all the answers. We're not going to be able to solve every problem, but we're willing to learn and work together and go on the journey. And in so doing, I think we connect better than we ever could before. Thank you so much. I hope you enjoyed it. And now we have a few minutes for questions if you guys have some time.
Thank you so much. There are definitely some updates, and not a question, but you got a kudos saying fabulous integrative presentation, which I concur with.
Thank you.
Let's see that. I know I had you're okay. So somebody had a question that relates to one that I had. The question was, what about a precision medicine approach? And I would put as a corollary to that, integrative and functional medicine overlap, but they're different. They're also different. And you alluded to like microbiome testing and the, availability of that. So what is your, how do you see in the field of integrative dermatology the role of precision medicine and functional medicine?
I think they're super important. I believe that in the future, we are driving towards a future where we're going to be able to say to a given patient, this is specifically what's awry in your case, and we're going to use X, Y, and Z to get those specific components better. And I think functional medicine really is seeking to do that, and in some situations really can. I think a lot of the stuff we're seeing, it's still too many variables for me to be confident in it for most of my patients, but I still think that those are going to be the practitioners who are on the bleeding edge. They're going to be the ones who are going to help solve this problem. But I get a little worried when, I think there's a certain amount of humility. I work with a great functional medicine doc who's pretty circumspect and says, I think we can try these things. We're going to do this. There's the limits of my knowledge. I feel very good. I've had other patients say, boy, that doc just kept saying, we know the exact answer. We're going to get you better. And they said, you just got to wait longer and pay me more. And that's frustrating, right? That's frustrating for all of us because the poor patient gets stuck in the middle. And you can use this leverage of guilt. Like, did you really cut out all the foods I told you? Are you really doing, and then it becomes this crazy thing. And of course, for parents of kids, they already carry the guilt. They feel that they've caused this or they've done something incorrect. So I think we'll see this played on, and regular conventional medicine doctors do this too. This is not anything specific, but I just feel like there can be this funny thing where you can put the blame on the patient by saying you're not doing enough. And I'm just very honestly, I'm willing to learn more and I'm fascinated, but as far as I understand, it's a little more complicated, I think, for a lot of these systems than we give it credit for. And thus, I don't think we're ready to be precision for all parts yet, but maybe I'm wrong. I'm willing to learn.
Yeah, and I would agree. I think we do some functional medicine as part of our care at the Osher Clinic, but with limits and with many caveats about the level of evidence about it at this point. So I agree with you there. And then a question from one of our providers, Dr. Shanahan, and it is that you briefly mentioned parabens. So what are, and I know you mentioned ways to DIY your own skincare products, but what are your thoughts about like the clean personal products, like those that are rated by the EWG? Do you recommend those? I've certainly seen that even some of the pharmaceutical skincare products have things like parabens in them, which we tend to encourage patients not to use. So I don't know, what are your thoughts about the role of environmental toxins in skincare?
I think, I actually am a fan of EWG. I know some people get upset because they sometimes can be kind of capricious. They'll put things on there and they don't always necessarily have great evidence for being against something. But I often feel like they're picking stuff that's really safe and really gentle. So I kind of like it. I lean on their list a lot. Sometimes I feel like we have to deviate. If I have patients who are allergic to known components of things, then it's like, we have to get something a little more, chemical or whatever. But it is tricky. And I think we keep learning about it. Sometimes I will say one caveat is that we'll sometimes jump from frying pan into the fire. An example of this is the parabens, right? So parabens have kind of gotten maligned. I think, in an ideal world, we wouldn't have preservatives. Like for example, one of the companies has solved this problem, which is brilliant, in their moisturizer cream by using a hermetically sealed sterile package. So it is truly a preservative-free cream base. There's water in there, which means yeast and, bacteria should grow, but they have it sterile in one-way valve. That to me is the future. But up until that point, most products need some kind of preservative. So parabens are pretty good. They've been around for a long time, but then they got maligned. So what did a lot of companies do? They switched to other ones, things like butylated hydroxytoluene and other things, some of which I think I'm more worried about. So I'm like, I get why you didn't like parabens, but I like this one even less. I'm actually more worried about this, but it's not out in the world yet. So people sort of say, oh, thank goodness it's parabens free. And it's like, but to what end? So we have to be thoughtful of that, just not having something, it's the old sugar-free Snackwell cookies. They must be okay. They're sugar-free, can eat as many you want. It's like, actually, or fat-free. They're not necessarily good for you. You picked the one thing you didn't want and worked around it. So I want to be more careful. That's why I like being more holistic. It's like, let's build our own stuff. Let's try to do things, smaller batches, local things. I love all that because then you can get out of these problems when you mass produce things.
Yeah, I agree. Where, like you said, fix one problem, just create 10 more. There were two other questions. One was, is there any benefits because we see these even in a lot of OTC products, things like hyaluronic acid and niacinamide as moisturizers and barrier protection in AD? So they're in a lot of products for just skin aging and other.
They are. And, it's one of those tough things. I mean, again, we have whole units on moisturization, whole universes there. So I didn't touch on a lot of things, of course, because this is like I say, giant. But yes, hyaluronic acid can be very helpful for a lot of patients. There are many different concepts being studied. The hardest part for us is we don't have a lot of comparative evidence. So, I could tell you my favorite things, what I like and what I use, but that's very different than what I think is the best, right? So you have to be kind of careful with that because I don't think we have good comparative evidence. And, I don't know, like, is even one of the wonderful studies Emma Gutman did at Mount Sinai was she did a study of petroleum, right? Petroleum jelly, and was able to show that it's amazing. Like it's an old treatment. It's dirt cheap. Some people don't like petroleum-based products, but it does a lot of good for the skin and it is incredibly, incredibly safe for the skin. Like it doesn't cause allergy, irritant. And, meanwhile, people are spending 10 times, 100 times, 1,000 times in the cosmetic range, right? 1,000 times per unit of volume for a cream that's supposed to be fancy, but I don't know, who knows, I guess, part of it is the cosmetic feel and so on, but there's a lot there. So again, I would say stay tuned, following the literature is interesting, but be careful because most of the studies are marketing studies. And that's one of our troubles because this company will say, look, it helped with wrinkles, or look, it helped make the skin more plump. But in isolation, it's like, okay, so does Vaseline,
Right. Yeah, I saw it at Macy's recently. Little jars, $10,000 right at the front when you walk in. Kind of crazy. Well, I know we're coming up on the hour, and I want to respect your time and everybody else's time. Thank you so much for your enlightening talk. It's always a pleasure to learn from you. I'm not sure if the presentation gets mailed out. There was a question about that, but it certainly gets posted on both IPHAM and on the Osher sites for grand rounds. So thank you
so much for
again.
having me. Take
Thank
care,
you.
everybody.
Don't forget, sign up for the longevity conference. Bye.